Good morning. It's a real pleasure to be with you here today and to talk about a topic that's very near and dear to our hearts, how we can make healthcare better. The title of the session is the Countdown for the Millennium Development Goals. Can improvement science help achieve the MDG targets? As Fiona said, I will be starting this presentation, and then I will be joined by my colleague and friend Ed Kelly from the World Health Organization in Geneva, who will pick up and talk to us about the future agenda going into the post-2015 era. What I'd like to cover today is to talk about the MDG goals, the Millennium Development Goals, and the importance of these goals to the global health agenda. I'd like to give a status update of where we are, some of the challenges, and why we are where we are on fulfilling this agenda. I'd then like to talk about the role that improvement science, the science that we're all here talking about, studying about, learning from each other about, how that can help us attain the MDG targets. And then I will hand over to my colleague, Ed, who will take us through what is happening in the post-MDG era, post-2015, what's likely to come up, and what are some of the conversations going forward. With that, if I can start, the first thing I'd like to start with is to give some background. On September 6th to 8th, 2000, in the year 2000, at the United Nations headquarters in New York, and as a result of a series of meetings and events that preceded that and culminated into what's called the Millennium Summit 2000, a UN Millennium Declaration was signed specifically to combat poverty, hunger, disease, illiteracy, environmental degradation, and discrimination against women. At that time, there were 189 member nations that signed up. Today, there are 193, just for the record. And at that time, also, 23 international organizations agreed together to work on the MDG goals, the Millennium Development Goals as we know them now. The Millennium Development Goals are 8, and they're all about developing human and social improvement. And they range across a number of issues related to poverty, education, gender, healthcare, environment, partnerships for development. 3 of those, the ones that I've highlighted in red, are the healthcare Millennium Development Goals. And those are to reduce child mortality, to improve maternal health, and to combat HIV, AIDS, malaria, and other diseases. I'd like to talk about those in a little bit more detail. I'm sorry about the small print here, but this is taken from the United Nations Target program, and these are I've taken out the 3 Health Millennium Development Goals. And those are child mortality. And as you can see, there's a little bit of detail there, but the short of it is that there was agreement that the United Nations member states will work together, and the international organizations will work together to reduce child mortality by 2/3. And they took 1990 as the starting date and 2015 as the end date. And for that period of time, the idea is reduce child mortality, under 5 mortality, by 2/3. Similarly, to work on improving maternal health, several items there, but the main one is to reduce maternal mortality by 3/4 over the same time period. And for HIV, AIDS, malaria, tuberculosis, other diseases, there was agreement to improve that by taking very specific actions to halt the spread of the epidemic and to reverse that epidemic. Now, with an agenda like this, what happened was there was a flurry of activity. Countries each worked on looking at their data and saying, what are their own Millennium Development Targets? So if you go to a Ministry of Health in a country, they will say, our target for this MDG goal is the following. And so they'll have numbers, and many of them have taken some serious action in order to work on attaining the Millennium Development Goal targets for their countries, contributing to the overall picture of achieving the MDG goals as set by the United Nations and the member states. What has been the progress so far? So, between the period 1990 and 2011, under 5 mortality, children under 5, their mortality rate has come down by 41%. The maternal mortality rate has come down by 47%. New HIV infections have come down by 21%. And by 2011, there were over 10 million patients who were alive on antiretroviral therapy treatment for AIDS. Mortality from malaria went down by 25%, and tuberculosis treatment, about 51 million individuals were given treatment, and there are an estimated 20 million lives saved as a result of that. Let me share with you the Millennium Development Goal scorecard. I'm only taking the 3 healthcare targets, goals. In spite of all the progress that I mentioned, you will notice that we are still short of reaching the MDG targets. Not because they are too high, not because we don't know how to do them. We're just short of doing that. And if you look at the scorecard, which again I apologize is a lot of detail, green means either achieved or on track to achieve. The yellow or the red means not on track to achieve, and red is actually no progress or further deterioration. You'll notice that in many parts of the world, and for many of the MDG goals, we're not even on track to achieve them over the next 2 years or so. And the question is why? And this is a place where we've delved in, we've tried to figure out what is going on, why are we so far from achieving what are seemingly doable, achievable targets and goals on a global scale. In the words of the Director General of the World Health Organization, Margaret Chan, she said, "The reality is straightforward. The power of existing interventions is not matched by the power of health systems to deliver them to those in greatest need in a comprehensive way and at an adequate scale." This is not very different from what 10 years ago, or more, the Institute of Medicine Crossing the Quality Chasm report stated. Between the healthcare that we have and the healthcare that we can have lies not only a gap, but a chasm. And the problems come from poor systems, not bad people. More recently, Dr. Jim Kim, the president of the World Bank, has been talking a lot about this. He's been saying things like the enormous investments that have been made in global health should have led to what we might have called a science of implementation and execution. We have just not focused on the enormous complexity of delivering healthcare in a way that keeps people healthy. In other words, what we're seeing is a picture that looks like this. We have many high-impact interventions that can save lives, that can alleviate human suffering. And for the most part, these are actually simple high-impact interventions, and they're also relatively cheap. They're not costly to implement. The issue that we have is not one of unavailability of the technologies, the interventions, the science, the know-how of what can help us attain the MDG goals. It's the lack of their implementation for every patient every time they are needed. Some of you may recognize this as the biggest issue we have in quality in healthcare. We talk about this a lot in our own work. We know what works, it's just not happening. Now, there are multiple efforts around the world, a whole lot of people, organizations, countries that are embarking on this. I'm going to mention just one of those efforts, the effort I'm personally involved in with several of my colleagues, many of whom are in this meeting and in this room with us today. The work that's happening under the USAID Healthcare Improvement Project, which is aimed at improving healthcare. This is a map of the globe. The countries that are colored are the countries where the project is active today. And those countries, different countries are addressing different healthcare priorities. As you can see, pretty much all the global health priorities are being addressed in one place or the other. In some countries where you see striped lines, more than one priority, global health priority, is being addressed. This is the follow-on project, which is now up and running, the USAID Applying Science to Strengthen and Improve Systems project. And countries, as they finish from one project, they move into the next, and they're picked up by the next project and continue their work. Now, what I'd like to share with you are some of the things that we're doing in contribution to the MDG targets that we have in those countries. This is a very quick overview. You can see that in different countries, we're addressing different MDG goals. And you can see some of them are actually outside of healthcare as well, because we are working in areas of caring for orphans and vulnerable children, as well as gender, which enable us to address other non-healthcare MDG goals. Here are some of the results that I'd like to share with you. The first result is about child health. And this is an early result that came from Honduras. And initially, what it's about is treating major killers of children, namely pneumonia and diarrhea. Now, the interventions for those are quite well known. They're very well established. Many countries have made significant progress using them. To give you an example, pneumonia can be treated very well with antibiotics, and diarrhea with oral rehydration or with intravenous rehydration if need be. The problem that we have isn't the lack of the intervention, what can save lives. It's the lack of its implementation. Let me give you an example. A child is brought to the health center and they're told, well, you actually need referral because you need to get this drug or the other. What happens is, between the time that they get to the center, they get referred, and then they get taken to the next place where the referral is, time passes for all sorts of good reasons, transport, money, etc., nobody at home to take care of the rest of the kids, whatever the good reasons are for the delay that happens. And as a result of delay in providing the care, what happens is these children suffer, and some of them are not saved, though the interventions are there. What they did in Honduras was to say, well, we are going to initiate the management of those illnesses in the community. So instead of saying you need to go somewhere, let's start maybe by not a very highly qualified health professional, but somebody who knows enough to be able to diagnose and initiate treatment and give referral. What this graph is showing you is the percentage of children with those that were referred that received their initial treatment in the community. You'll see some red dots. Those are counts of deaths of children in that community. As you can see, a very simple intervention or interventions operationalized in ways that are very appropriate to the context can lead to significant reductions in mortality. A similar example from Nicaragua. This is now at a different level. These are children with newborns with sepsis in hospitals. And this is the case fatality for neonatal sepsis in 4 hospitals, again through a series of simple operationalization of what we know to work in order to treat sepsis in the hospitals. This other result comes from Mali. And I saw our colleague, Mayna Bukar, who led this effort, to walk into the room. He's here with us right now. And he can talk to you more about it. This is the implementation of a simple, high-impact intervention that's called the active management of the 3rd stage of labor for women who are delivering. And it's something that can be done. The blue line, the dark blue line at the top, shows you the all-or-nothing implementation of all 3 elements of the active management of the 3rd stage of labor, skyrocketing as a result of very simple operationalization of how it can be done, contextually appropriate implementation, and the line under the pink line underneath shows the drop in postpartum hemorrhage, which is the #1 cause of maternal mortality. As you can see, the contextually appropriate operationalization of simple high-impact interventions can yield very significant results and save lives. This is a little bit more complicated. This is from Uganda, and this is about using a chronic care model to manage patients who need to be on treatment, on antiretroviral therapy. I'll go through it very quickly, but basically the black line at the top is an estimate of the number of patients who need to be on treatment. The pink line underneath that is the number of patients ever started on treatment. Between those 2 lines is what's called the coverage gap. That is, of the patients who need to be on treatment, how many were actually started on that treatment. The blue line underneath the pink subtracts out those that legitimately transferred out. Either they passed away or they are receiving care elsewhere or for whatever good reason, but they're not lost to follow-up. And the orange line underneath that shows those that are coming back on a regular basis. That is, they stay in treatment. Between the blue and the orange line is the retention gap. One of the things that we notice that it's not just about putting patients on treatment, AIDS patients on treatment. It's about maintaining them on treatment over time. And the green line is the line that shows those that are doing well on treatment. Between the orange and the green line is what we would call the wellness gap. That is, if somebody is maintained on treatment, are they actually doing well on it? So basically, it becomes very simple to understand management of AIDS patients. Those that need treatment are put on treatment. Those that are put on treatment stay on treatment. And those that stay on treatment do well on treatment. And you can see the difference between the starting point and the red line, that the vertical red line, orange line, is the end of the technical assistance to those 4 or 5 healthcare centers where this work was done. And the data after that is basically continuing data independent of technical assistance from the project. And as you can see, it's all very the results are amazing to see. You've got reductions of about a half to 2/3 in those gaps in quality of care. Now, how do we do this? Let me go through a few things. The first thing is we know the high-impact interventions, and what we need to do, which is all very well known to you, and you'll hear a lot about it in this conference, is how do we reorganize care delivery to enable the implementation of these high-impact interventions for every patient who needs them. What we do is we test different changes and see if they work, and if they do, we institute them, and if not, then we can either take them out or we can change them in order to make them happen. We understand the same principles that are applied in all other work in improvement, the same ones, understanding our work as processes and systems, every one of them having performance as a characteristic of the way this care system works, team members developing the solutions, the focus being on the patients, testing and measuring different changes to see if they've yielded improvements or not. And a very big learning for us is how we share the learning across multiple sites that are learning from each other and make that available globally. And last but not least, it's all about engaging people's minds and hearts in order to do so. As you can see, what I've tried to do here is to say, here's the status of the global health agenda. Here are some ideas as to why some of these simple, high-impact interventions are not happening for every patient who needs them. I've given you a few examples that show achievement along this work, and it's using the very same science of improvement that all of us are here studying and learning about. What I'd like to do now is to ask my colleague Ed Kelly to take us through the next part of this presentation, which is about the post-Millennium Development Goal agenda. Thank you. Thanks.
Well, first of all, thanks to Rashad and to Jean-Luc and to Fiona for letting me unannounced join you on the stage here, and congratulations to BMJ, IHI, and the Health Foundation for such a successful start. My job is to just frame the issue of the Millennium Development Goals and the post-Millennium Development Goal era as WHO, to sort of offer some kind of benediction on the talk and not have a sort of off-the-wall discussion on the Millennium Development Goals, mainly because there's such noise around what the priorities are going to be. And I'll just end in a moment with the idea that while we need innovation, this whole idea of prioritization is very key to what we need to do. Briefly, because Rashad introduced it very well, there was a discussion, and some of you working in the MDG world may forget that we're actually still in the MDG era. We're not in the post-MDG era. That's next year. But there's been a work by the UN at a very high level, at the highest level, the UN Secretary General, to look at the post-MDG agenda. And you can see the vast effort at consultation that's gone on with this. And the panel, this high-level panel that was pulled together by the Secretary General, recommended 5 transformative shifts, quote unquote, and 12 illustrative goals. And if the 12 goals were carried out, the 5 shifts would be achieved. Now, this is all in the context of trying to think, where do we focus both the significant donor community dollars as well as the much bigger national budgets in terms of making change and improving people's lives globally. The 5 transformative shifts that the high-level panel talked about, and there's a number of excellent documents on this, were to first leave no one behind. Second, put sustainable development at the core. So the first being an issue of equity, and there are a number, this is carried through, and the World Bank has a new approach to looking at equity and at-risk groups. But the putting sustainable development at the core looks at how you keep development on the agenda in countries and do it without external assistance constantly. Looking to transform economies for jobs and inclusive growth, building peace and effective, open, accountable institutions for all, and forging new global partnerships. Obviously, all of those are relevant to health. 1, 2, and 5 are perhaps most relevant. At the same time, there's a big discussion about what determines health, and Maureen made excellent reference to the fact that all of us, as someone who's worked in the quality world for many years, but who now heads a department at WHO called the Service Delivery and Safety Department. So we moved from being the World Alliance for Patient Safety and focusing on avoidable harm and issues around that, coming out of the IOM report, and the UK is an organization with the memory reports, to looking at safety and quality and improvement science as ways of achieving broader goals of improving health services and improving health. Even one step above that are these this Rio 20 plus discussions around the social determinants of health, which was held in Brazil in June 2012, and they were agreed that two processes need to be closely linked: the discussion on Sustainable Development Goals and the MDGs. Now, for some of you that may be normal, but everybody in all organizations, the UN included, have their agendas. And when you are concerned with energy and education, you don't want money going to health. That's the sort of nature of the game. There's a zero-sum discussion going on. And so the idea that these two would be closely linked was an important element in terms of preparing the groundwork for this working group that moved forward on it. These are the 12 illustrative goals, and number 4, I won't go through them all, but number 4, in terms of ensuring healthy lives, was one of the important set of goals that were on there, and these link from these 5 transformative shifts that I mentioned earlier. The challenges, I think, that exist is that for WHO, our work is to ensure that health and health systems are strengthened around the world. The goal that has come out is perhaps that this discussion of moving upstream on some of this health work and looking at education and environment may leave investment in health out. And I think this whole discussion, Maureen once again admonished us earlier to be in discussions with our finance people. This is the same discussion that happens at ministry level. We do not have the engagement of the ministries of finance. Most of them look at health as a cost driver within the economies rather than an economic production factory. When we look at health and the next agenda, the big goal for WHO is universal health coverage, UHC. And we have been working in many countries, the US included, with colleagues here in France as well, looking at models of universal health coverage and how they can be expanded in a quality way. Our own Director General talked about, though, we cannot just be expanding access to poor quality care with undertrained staff. What good does it do to offer free maternal care and have a high proportion of babies delivered in health facilities if the quality of care is substandard or even dangerous? I've been in 3 countries in the past 4 weeks, South Africa, Ghana, and the United States. All of them are expanding access to services. All of them had front-page articles on the poor quality of that expanded access. In the US, it happened to be on long-term care, in Ghana on maternal and child health, and in South Africa on palliative care for HIV. And all of them were huge headaches for those ministers of health while I was there. This is an agenda that I think we need to tackle. This is the universal health coverage definition that looks at expanding, ensuring people have access to needed services, and that the access to these services don't expose individuals to hardship. But I think, coming to my earlier theme of the convergence of some of these equity agendas, there's been work on primary care, work on equity, and work on universal health coverage at a global level. All of these now are coming together in a very unique way that I think creates an opportunity for us. Now, improving services in the post-Millennium Development Goal world, Rashad's talked about this. For us, we look at 4 strong themes, that all of which are supported by work in improvement science: empowering communities, families, and patients; stewardship in terms of improving accountability; then the designing, coordinating, and improving services at the point of care; and finally, setting priorities and national quality policies. Now, the work that Rashad's highlighted are some excellent examples that I would encourage people to go to, and perhaps we can persuade Maureen and some of the others here to use some of these examples looking at the developing world. If you look at TB just as an example, they've been years looking at patient empowerment. In terms of integration of care, there's a lot of work that's gone on in countries looking at community integration. in terms of services. We have a project right now taking lessons we learned in Ghana and applying it to inner city Baltimore. So this reverse innovation and this South-South and South-North collaboration on some of these issues at a country level takes the principles of improvement science and applies it at a national level. And I think that's one of the priorities we should be examining. But none of these concepts, patient-centeredness, integration, are brand new. There's new, shall we say, what in what we're talking about. That what we are up here to talk about today is really that there is a new way to think about the how of what we do, both at a clinic level, at a sub-national level, at a national level, and even at a global level. The issues on innovation are important. You will have tons and tons of fascinating presentations of very innovative approaches here at this conference. But part of the work also is around prioritization and setting very high-level priorities and sticking with that. And finally, the last piece in terms of the triumvirate there of innovation, prioritization would be implementation. And I think this work on improvement science presents us with an opportunity to take the post-MDG goal area and make it into one where that scorecard that Rashad showed you, where we have not done the implementation that's needed, and to have the next scorecard on the post-MDG era all in green. So I'll conclude with that, and thanks very much.
Thanks, Ed. Thank you very much, Ed, and thank you, Rashad. I wonder if I can encourage, could the lights come up a little bit, and if anyone would like to ask the speakers questions. Seeing if I can see any movement. While you're all thinking about whether you'll ask a question, can I just ask one? I mean, you said about the issue about the need for, the quote from Jim Kim about the fact that we just haven't focused on implementation, and your point, Ed, about the fact that that's the third thing we've got to focus. Is there an investment, financial investment gap that we need to meet, or is it a question of us not understanding how to go about investing in implementation? Where would you put yourself on that? Rashad.
So, if I can say, I think when he refers to implementation, execution, I would add the word improvement there. I think we're talking about the same science of how to take what is known to work and make it happen for every patient every time it's needed. And we can use those terms interchangeably. What I think has happened is that the science of improvement, implementation, execution, its application has been limited, and I don't think it's been as widely applied in global health as it should be. A lot of work is happening, but nothing like as much as should. And I hope that going forward, there will be much more use of that. There's a tendency to focus on what works rather than think about how to make that happen for every patient every time. And this is where I think everybody in this room comes into play.
And just to pick up on that, Ed, you said there's a new way to think about the how of what we do. Would you just give us a kind of one sentence again of when you say the new way, what should people take away from that, and how can they contribute to the new way?
Yeah. It'll be longer than one sentence, but I'll make it try and make it two. But
a tweet. You've got 140 characters.
Let's see, 44 characters. I think we just had, as an example, a meeting. Rashad was there. A colleague, Enrique Reales, is in the audience. Is there? A number of other people were there at WHO on Monday. A new global report that WHO, the OECD, and the World Bank will put out on quality and safety of health services in 2015. The takeaway quote I had from the meeting, we had a fantastic group of people, was that in most of these countries we're talking about, it is not primarily an issue of resources. That's the same issue in the United States as it would be in Ghana and South Africa. There are some exceptions, but mostly it's not a question of resources. It's a question of the management and leadership of those resources. Secondly, there's not one solution for any country or any hospital or any clinic. These are general principles that then need to be applied locally. And I think this example, we had an earlier example of the care model that Maureen talked about and the ones that Rashad talked about, is that the general principles, simple rules, need to then be applied locally. And I think that's really part of the new way. That's not the way WHO works. It likes to work with big resolutions that says the whole world must do this. And I think that'll be a big shift for some organizations.
Thank you very much. We have a question. Could you say who you are? Number 5.
Microphone on? Great. I'm Joanne Conroy, Chief Healthcare Officer at the Association of American Medical Colleges in Washington. So a comment and a question. So a comment, I saw that you put developing countries up there in terms of the kind of international goals. It would have been nice to see the U.S. included, because I think we self-criticize ourselves that we actually don't perform very well on the national stage. So just a comment. Don't leave us out. The second piece, though, is the question. Implementation science is something that we're thinking about a lot in the U.S. And what are you doing to actually integrate it into the education of health professionals, not just physicians, but nurses, allied health professionals, to really understand implementation science? If it's not integrated in their education, I think they think it's just another tool, another add-on, another additional thing they have to do, rather than a way of thinking differently. And so I'd be interested in your thoughts.
Joanne, thank you very much. Rashad.
Thank you. Great comment. Thank you for that. There is some work going on at different medical nursing schools, others in terms of taking implementation science, improvement science, integrating it into the curricula. I don't think there's enough of that happening. We have a number of colleagues who are engaged with different groups trying to do that. In fact, interestingly for me, we're working with a group of African institutions that are developing competencies in improvement in Africa. I'd love to see that happen, not just in Africa, but also in other places. So I totally agree, and I don't think there's nearly enough of that going on. And if you have any ideas how we can work together on that, we'd love to engage with you.
Maybe just to add quickly, to complement the work that Rashad mentions, WHO has had, for the past 2-3 years, work on a multi-professional curriculum guide on safety and quality, which, as you know, getting curricula changed at any institution is a very difficult job that has very serious deans who say, how much is this going to cost, and all of the work that's done. This guide basically puts out a how to teach these subjects and then some of the raw materials for it. So we've worked with IHI and Open School in some ways on this, but I think we had a question with the Director General just yesterday about how are we really going to make change in a session with her. And I highlighted that, well, if you look at the airline industry, the recent issues in Malaysia notwithstanding, the way that they have made progress is with the basic education, but then recertification. I would bet you, although this statistic is not validated, that you would be looking at less than a third of health professionals currently practicing globally have been recertified in the past 4 or 5 years, and I think that's just not acceptable. So I think there's an education and a recertification piece that needs to be brought in.
Thank you very much. And a question here.
Hi. Yeah, my name's Ewan McPhee. I'm a GP obstetrician from a small rural town in Queensland, Australia. I came to the conference really interested about quality improvement and quality science, and from a primary care perspective, I see a lot of stuff happening in hospitals and tertiary centres, but not a lot happening in primary care. Really interested in your insight into that.
Thank you. Rashad.
Sure. Well, a lot of this is primary care. So deliveries are actually, these are health centers that I was showing also, the triage in the community and the initiation of treatment in the community in Honduras, the health centers in Uganda. In fact, I would go so far as to say the majority of the work that we get engaged in is more at the primary point of contact rather than the referrals. So it's just as applicable, if not more, at the primary point of contact. Let me say another thing here, which is very important. In order to improve care, we have to look at the care provision across the continuum. The bulk of it happens in the community. Let me give you an example of when I say the bulk. Like one of my colleagues who's here at this meeting, Mirwas Rahimzai, led a major effort in Afghanistan on reducing maternal and neonatal mortality. Well, 80% of deliveries happen at home. The majority of his work were in the homes with traditional birth attendants, but they couldn't exclude the referrals because that's where complications need to be managed. In order to get better outcomes, we have to look at all the continuum that produces the outcome of interest.
Thank you.
Yeah.
Just hold your comments if you
Sure.
wouldn't mind, sorry, because I'm going to invite the person behind you. Sorry, sir, there's one behind you. And then...
We have on one hand the statements.
Could you say who you are?
Enrique Ruelas from Mexico.
Bravo, thanks.
We have on the one hand the statements by WHO saying what has to be done. And for many countries that's a must, so they have to. On the other hand, we have the presentation by Rashad of a very practical ways of implementing things. When we face governments, we have a challenge because many governments think that a must has to be implemented through laws, regulations, orders, and that's it. How to approach a government, either national, regional, local, to convince them or to promote that improving is not only issuing laws, regulations, and giving orders, and perhaps threatening with punishment if someone doesn't do what WHO wants to be done.
Thank you. I think that's a question for Ed.
I knew I shouldn't have highlighted the fact that Enrique was here, but I think it's an excellent question. I would say no sort of one country is the same, but I think the main issue, and this is what I would comment on, just to add to Rashad's piece on primary care, is the first piece is having some data on the scope of the problem. And that's been the biggest problem we've had in primary care. We've got good examples, but at national levels, they're very poor data systems, generally speaking, on how to make improvement happen in primary care. So data, then having a case study of what works, so some of these things that Rashad's talked about, and then I think you have to make the economic argument, because even if they're sold on doing this, they'll have to talk to their ministries of finance. I mentioned the issue of policy at the very end. Our own work on some of this stuff, you get to a certain point in some of the countries where Rashad's work, where WHO works, where you've got countries bought in, you don't get sustainability unless you have that policy piece that you must do this framework that allows some of the early adopters to really take it and spread it.
I'm just going to take an opportunity now. We probably need to move on, but Emma here is our info DJ, and you may have noticed this very high-tech passing of notes between us on paper, that wonderful technology. And just to say, I won't probably have time to put these to the panel, but I just thought I'd share them. Martin asks, have you achieved more than Health for All 2000, and if so, how? And we have a question here from Senga, and reiterated by Tana, how do we integrate improvement science in curriculums so that it becomes the way we work? I think that's going to be a real challenge for the entire conference and for us generally as we take all of these learning home. So with that, I'm going to call a close to the first half of the session with thank you very much to Rashad and to Ed.